Good morning, everybody. And it is a lovely day. The sun is shining, the weather is warmer, and it's a beautiful way to start our Friday with all of you this morning. Welcome, everybody. On behalf of the Black Midwifery Collective and Health and Medicine Policy Research Group, we are so excited that you are here joining us for the second event in our four-part Illinois Community-Based Birth Justice Strategic Plan Launch Series. My name is Anna Yankelev, and I will still be your host. I'm the Director of Strategic Workforce Initiatives at Health and Medicine, and I've been working closely with the Black Midwifery Collective to facilitate the strategic planning process and develop the plan itself. Over the past year and a half, dozens of community-based birth justice workers have supported the development of a new strategic plan that works to ensure that every birthing person in Illinois has access to the community resources, settings, and support that they need for a safe and positive perinatal and birth experience. Simultaneously, several researchers conducted surveys, focus groups, and key informant interviews with community-based birth workers to better understand their barriers, needs, and priorities. These findings together helped inform the key themes that shape the evidence-based foundation for our strategic plan. In this four-part webinar series, we will review the findings from these different research projects and culminate in an overview and release of the new strategic plan during the last session. You are welcome to join for any combination of the webinars based on your interest and availability, and we will, of course, make recordings of the sessions available after the series concludes. Today's session features two research projects that explore the barriers, needs, and opportunities for the broader birth justice workforce in Illinois. Last week's session focused predominantly on the realities facing doulas, midwives, and birth centers, and this one will dive deeper into the full array of roles that support community-based birth justice, including community health workers, peer support workers, social workers, clinicians, and others, with a special focus on the needs and priorities of those in Southern Illinois. After we go through some housekeeping, we will provide some key terms and provide a brief introduction to birth justice and why this work is so critical. Then, Nora and Chastity will each go through their research and share their findings and recommendations. We hope to have some time at the end for a nice Q&A. For those of you who joined us last week, the next 7 minutes or so will be pretty much the same as to what we covered in the beginning of last week's session, so feel free to go refresh your beverage or finish that last email before we get started with the research. But otherwise, I'm going to catch everybody else up to speed with some housekeeping notes. Please introduce yourself in the chat if you have not done so already. We will be recording and translating these webinars, and those will be available after the sessions conclude. As I mentioned before, we will have a 15 to 20-minute Q&A at the end, and be sure to put your Q&As in the Q&A function and not in the chat box, just so we can keep all those questions straight. Quick review of some key terms so that we are all working from the same definitions. Perinatal refers to the time period from when someone becomes pregnant to a year after giving birth. When we're talking about community-based, we're talking about culturally congruent care that happens outside of the health and hospital systems. And when we're talking about birth justice, we are talking about the right to choose whether or not to carry a pregnancy, the right to choose where, when, how, and with whom to birth, and the right to breastfeeding support. And we are, of course, continually grateful for Jamara Amani's leadership from the Southern Birth Justice Network for this definition. And a quick note on gendered language. While we strive to use gender-neutral terms to describe birthing people wherever possible, we do use some gendered terms like women or maternal when referencing research that utilizes those terms. Why do we need this plan? Illinois has a big problem. Not every birthing person in Illinois has the same opportunity for a safe and healthy birth experience that leads to serious injuries and death that are often preventable that impact some communities more than others. Avoidable and unfair differences in health outcomes like these are known as health inequities. So we believe that we need to achieve birth justice in order to eliminate these health inequities. So which communities are more likely to experience perinatal health inequities? Black women are more than twice as likely as white women to die from a pregnancy-related cause, and in Chicago, that number jumps up to 6.5 times as likely. Black women are also more than twice as likely to have a potentially life-threatening condition or complication during labor and delivery when compared to white women. And women on Medicaid are more than 3 times more likely to die from a pregnancy-related cause than women with private insurance. And this is particularly important because 40% of all births in Illinois are covered by Medicaid. Older women more than 40 years older, and women with a high school education or less are also more likely to die from pregnancy-related causes. And it's important to note that while recent years have shown improvements to mortality rates for birthing people overall, rates for Black birthing people in particular have remained unchanged and in some cases have worsened over time. Notably, 1 in 3 deaths occur during pregnancy and 1 in 3 occur more than 60 days postpartum, which means that the majority of maternal deaths are not occurring during labor and delivery. And importantly and horrifically, 9 in 10 pregnancy-related deaths are at least, quote, somewhat preventable. And this statistic right here is ultimately what we are trying to change with this strategic plan. So our plan explores what we can do to help eliminate these preventable deaths and promote the health and vitality of all birthing people. So what causes these inequities? For many people, especially those from communities of color, immigrant communities, and rural communities, accessing comprehensive perinatal care in health and hospital systems can be difficult or even dangerous because not everybody can get the care they need, either because they live in a perinatal care desert, like residents in 1 in 3 Illinois counties do, or because they simply can't afford the care they need. There simply aren't enough workers to meet the demand, either within the health systems or in community-based spaces, and our first 2 sessions are diving into this issue in much greater detail. Racism and discrimination prevent many people from receiving or seeking care, and many women report experiences of dismissal, discrimination, and disrespect due to their race, insurance status, immigration status, age, or substance use. Our 3rd session will dive more deeply into this issue. Many birthing people have pre-existing or new medical, mental health, or substance use conditions that need dedicated care beyond the walls of the delivery room. And finally, those struggling with access to healthcare, safe housing, healthy food, reliable transportation, livable wages, childcare, and other factors known as the social determinants of health also experience worse maternal health outcomes. Many birthing people must navigate multiple of these barriers in order to get the care they need, and often these barriers impact and intersect with one another. This can make the conventional perinatal system inaccessible and in some cases harmful for many birthing people, particularly for communities most impacted by the maternal health inequities we just discussed. We believe that community-based birth resources and supports can address these barriers and advance birth justice. Our strategic plan, to be released at the end of the month, provides lots of evidence as to how community-based birth resources and supports, either on their own or in combination with health and hospital systems, are proven strategies to improve health outcomes for birthing people, reduce barriers to care, and reduce healthcare costs. So I'm not going to go into all of that now. Please join us for session 4 if you want to know more there. But we do know that we have a long way to go before we can ensure that everybody has access to the community-based resources and supports that they need and deserve. Our session today, Barriers, Needs, and Opportunities for the Broader Birth Justice Workforce in Illinois, focuses on the full spectrum of community-based birth workers, including doulas and midwives, but also community health workers, substance use counselors, social workers, clinicians, and others. I'm going to introduce both of our speakers now, and we will start with Nora's research and then move over to Chastity's. We will address all questions from the Q&A at the end, so please be specific in your question if it's for a particular researcher. Nora Kropp has over 30 years of experience as a perinatal health researcher and organizer. Nora trained as a midwife in Nepal and at Maternidad de la Luz in El Paso, Texas. She has worked in a rural home birth practice in North Carolina, in family planning and abortion services at Planned Parenthood in Chicago, and is currently a birth assistant at PCC Wellness Birth Center in Berwyn, Illinois. Nora has worked with perinatal health research teams in the US, Mexico, Asia, and South America. She lived in India for 10 years, where she co-founded the Bangalore Birth Network and helped incubate a freestanding birth center. Nora currently does development research and advocacy work with the Black Midwifery Collective in Chicago. Chastity Mays is the co-administrator for the Little Resource Center Carbondale and has held a formal doula certification for 6 years. She has worked in family service and peer support spaces for over 15 years and has served clients in Southern Illinois, the Missouri Boot Heel area, and Paducah, Kentucky. She stands with and advocates for families who are underrepresented and in many cases simply not heard at all. Chastity serves on the Carbondale Public Library Board, the Birth Equity Committee for the Southern Illinois Healthcare Labor and Delivery Unit at Carbondale Memorial Hospital, and the Promoting Vaginal Birth Committee with Southern Illinois Healthcare. She is routinely involved in state and regional political efforts around Black maternal health and frequently presents her expertise in public forums, conferences, and legislative testimony. Thank you so much, both of you, for joining us this morning. And Nora, take it away.
Hi, everyone. Thank you, Anna, for that amazing introduction. Thank you so much. I am Nora Kropp. I'm a certified professional midwife, and I do research at Black Midwifery Collective. And excited to be here today to talk to you about the survey we did with community-based workers in Illinois in 2025. So this survey was positioned as phase one of the multi-phase project to develop the state strategic plan. And it happened in early 2025, around the same time that the other research projects that you're hearing about in these series happened as well. And the gold star, that's where we are now in the process. So this study, the purpose was to improve our understanding of the barriers and facilitators or the things that make it harder or easier for community-based perinatal providers or service workers to identify those factors that they face while carrying out their work, and to inform the 2-day summit that was phase two of this project, to inform the speakers and the sessions for that, and to contribute to the development of the state strategic plan itself. Here you can see Nicolette Moore with the guidance of Dr. Chiari Kershaw at Northwestern University Feinberg School of Medicine. She designed the survey, handled all the technical aspects of the drafting, programming, disseminating the survey, and did the data analysis, the results of which we'll see today. And our coordinating committee. This coordinating committee met monthly throughout the project and advised on the content of the survey, the language, and helped in the survey and helped with the dissemination, which I'll talk about later. And Anna reviewed the survey and gave us feedback as well. So the survey had about 45 questions, which were mostly quantitative, check the box. Some open-ended questions. We'll be sharing the text from those as well. It was an online survey that took about 30 to 40 minutes to complete, and it was available in English and Spanish. We looked at the demographics of the service providers that you see listed there, and the demographics of the people they serve. That was limited to race, the kind of insurance used, and the geographic area. And then we asked community-based workers about the availability of perinatal services, their level of satisfaction with those, the level of accessibility of those services. We asked about compensation, benefits, work-related stress, and policy related to their work. Just to give some context, this is a detailed list of factors we asked about. And in any given response, when I'm showing the results today, we just give like the top 5 or 6 responses from the respondents. So the basic inclusion criteria were that workers needed to be 18 years or older, reside in Illinois, serve clients in Illinois. And in the next few slides, I'll give a little more detail about the remaining criteria. We wanted to focus on, oh, this is not very clear, the map. We wanted to focus on the high-risk maternal counties for the purpose of this survey, so not all Illinois counties. And in order to determine this, we consulted with Kara Burgo, who is the maternal mortality epidemiologist at the Illinois Department of Public Health. And we identified counties that have high perinatal risk. And these are counties that have one or more of the following characteristics. Give me one second. Okay, so they're high maternal mortality rate, high severe maternal morbidity, high risk comorbidities, which are hypertension, diabetes, and obesity, along with a greater than 30% Medicaid use in the county, and or a substance use disorder reported rate in the county of greater than 16%. Those were the counties that were included. So there are recognized definitions for reproductive justice and birth justice that we drew upon for this project. However, we did not find a standard definition for community-based. So we worked with the coordinating committee to create this definition. Anna covered a bit of it before, but the way that we found it easiest to like draw parameters around who's going to be included in the study and who's not, and ultimately in the project was laying out the definition relationship-based, equity-centered, but also and in unjustly served communities, but also to define the settings we're talking about. That was the easiest way for us to like put a box around it. So behavioral health centers, birth centers, community-based organizations, FQHCs, independent practices, people who work in individuals' homes and in local health departments. The categories of community-based workers included in this survey are here. So it's anyone from abortion and reproductive health, birth center, midwifery care, community health workers, doulas, home birth services, home visiting, lactation support, people who help people access Medicaid services, mental health, migrant health, and people who support people with substance use. It was a multi-step process for recruitment, and I just want to spend a little time on the recruitment process because it illustrates the effort and the joint effort it took to ensure representation from across the state. And it took this whole team of trusted coordinating committee members to get responses from across the state. So first, the coordinating committee members nominated people. And they suggested names and email contacts of 10 to 20 people in their networks who met this eligibility criteria. And then we cut out all the duplicates. And then the coordinating committee members wrote to the people they nominated and they said, hey, you know, we're doing this survey and we'd really like your feedback on it. So please look out for it. And then in the next 24 to 48 hours, Nicolette at Northwestern sent out the online survey. And so then people knew to look out for it and they knew where it originated and what the purpose was and who it was coming from. And then as responses came in, we monitored for underrepresented areas. So mainly geographic areas that were unrepresented or professions that we hadn't heard enough response from. Went back to our coordinating committee members and we said, hey, do you know any home visitors in, you know, the northern counties? And can you, you know, help us recruit people for the survey. And it was just kind of a loop like that. And then finally, we added a question at the end of the survey asking respondents to please suggest someone in their area who they thought would be good match for this. And in some cases, we would even say outside of Cook County because we already had enough response from Cook County or we had a large amount of people from Cook. So that's how we handled that. And what did we learn? So, give me a sec. Okay. So we wanted to get 100 surveys filled and we reached 78. So we didn't quite get there. And I just wanted to stay on the top that this is a small sample size, and so the results are not representative of any profession or geographic area, and it's not intended to draw overarching conclusions from. It's really the results were more intended to provide a window of insight for planning the summit and for the types of issues that we would come up with in the state strategic plan. And so, with that said, the ineligible included people who usually just didn't work in a community-based setting or worked in a county outside of the counties that we were looking at. About three-fourths of the respondents work full-time, providing community-based perinatal care or support. And regarding income, about half earn between 30 and 60,000. An additional like one-fourth made less than 30,000. And about 15% made more than 60,000. In terms of years of experience, close to half of the respondents had 1 to 5 years of experience in their profession. And the other almost half had 6 to 10 or over 10 years. So, about an even split between people who are newer to the profession and people who are much more experienced in their profession. In terms of occupation, we asked people what best describes their occupation, and they were able to mark more than one answer. So the doulas, home visitors, and lactation consultants were the most common. And because this was a select all that apply, we can assume that many of the respondents act in more than one capacity, right? So a doula who's also a CHW or a home visitor who's also a doula, that kind of thing. When we asked which counties they serve, they again could select all that applies, and they only the high-risk maternal health counties that I talked about earlier are included, not all counties. About one-fourth of the sample was from Region 2, which is Cook, Kankakee, and Kendall, and a relatively even distribution in the rest of the regions. The least number of respondents were from either up in Region 1, like Boone, Stevenson, Winnebago, that area, or Region 5 in the southernmost counties. And luckily, Chastity is going to be doing a very detailed dive into the southern counties after me. We asked people about their primary work setting, so where they spent 50% or more of their time. And here they were only allowed to check one. And so we can see that about 60% of the respondents work in community-based organizations or independent practices. So this is definitely an understudied work population, I would say. And the remaining about a third of respondents work in local health departments, behavioral health centers, federally qualified health centers, and 7% at birth centers. And these are much more structured work environments, very different salaries, benefits, supports. So again, tough to generalize results here. The majority of clients served used Medicaid, so 65%, and were Black, white, or Hispanic in that order. On the right, for the race of clients served, again, people could choose more than one option for the race of the clients they serve. So that's why the percentages are more than 100% there. And the first area that we asked about were programs and services. Oops. Oh, hey. Okay. So we first asked about the perinatal programs and services participants were most dissatisfied with, and 53%, obstetric care, then maternal health, childbirth education, lactation support, and support for people with substance use. And we diving a little deeper into it, you can see this doula from Champaign says Champaign County has only one delivering hospital. The next closest hospitals are Danville, Bloomington, and there are no accessible options such as birth centers or home birth midwives. A CPM in Rock Island, the only federally funded obstetric care unit is at capacity and not able to serve more patients. Very few doulas in general, and even less childbirth education options. And this was translated from the Spanish from a mental health provider in the northern counties with a plea to increase informed attention to trauma, mental health support for people with substance use, and increasing cultural sensitivity. So those were some of the details behind those numbers. Overall, about 59% of respondents said they were somewhat or extremely dissatisfied with perinatal programs and services in their region. The top reason for dissatisfaction was the lack of acceptability of services. So that would include like translation, cultural awareness, lack of trauma-informed care. And then a close second, which is closely related, was the unavailability of racially concordant care. And then cost, location, and poor referral services came in after that. And just to give a little detail there, a midwife from Cook County, she says racially concordant care is not nearly as accessible or available to all people in all parts of Chicago area, both with community midwives and nurse midwives, and it's not available in all settings, home, birth center, hospital. Doula in Madison and St. Clair just said increase the availability of this racially concordant and culturally competent care. Home visitor in DeKalb, not enough diversity in the staff. And diversity isn't just about race, it encompasses many factors, including economic status, cultural background, and even where you live. So a doula in Champaign says clients are receiving consents, documents, and discharge paperwork in English and being told there's no way for them to give it to them in the language they speak, including Spanish and French documents. Many of my non-English proficient clients do not fully understand the care they are getting, and there are often times where providers begin to administer care before the translator is online. Regarding cost, financial, the financial burden of just perinatal care, including prenatal, postpartum support, and lactation, can be prohibitive for many families, says a doula in Madison and St. Clair. Doula and a lactation counselor in Champaign, Vermilion. She says, providing translation services has been an ongoing issue. I've observed and advocated for families in which providers are not utilizing translation lines with families who do not speak English. Mental health therapy services are basically not available for people without private insurance. And even then, sometimes they have a barrier to pay. I think that's something very relatable and not unexpected. Transportation services are offered, says this doula and lactation counselor in Champaign, but there are no drivers. The insurance companies have contracted with transportation companies who can't provide the services offered. Families are following the expected protocol and having to cancel appointments the day of service because they don't have the transportation. And a doula in Sangamon says transportation continues to be the biggest barrier to prenatal care in her area, along with childcare. Workforce barriers and positive factors. So a lack of integration into the medical system, and again, closely related lack of knowledge about this profession in the community were the two top barriers reported for carrying out their work. This was a bit of a surprise, but it really was a standout. Stress, inconsistent pay, lack of benefits, stress, and lack of culturally congruent mentors, colleagues, and peers came in after that, showing that not just from the client side, but from the service provider side as well, lack of diversity is a major stressor. Regarding the dominant theme of integration and awareness, this doula in Champaign says, when starting as a doula, the manager of the L&D took us around, showed us everything, but none of that information was passed on to the nurses. And it varies on the provider of how involved or cooperatively they work with the doula. Some providers lean on me heavily, while others don't acknowledge me for the entire birth. Um, Lactation consultant in Madison, St. Clair, says integrate doulas, lactation, and culturally congruent care providers into referral systems and shared EHM and EMR systems. Mental health provider to recommends improving referral systems to ensure smooth handoff. And then a midwife and cook talks about continuing education and other opportunities for OBs to learn how to collaborate with other perinatal care providers. So an upskilling opportunity there for in-hospital providers. Factors that made it easier to carry out their work. The standout was positive relationships with clients. So the relationship-based care that we are known for was a massive positive for these workers. Availability of training and support for training, certification or education, those were high. Connection to the professional community because a lot of people work in isolation. So that connection was really important. Adequate scope of work. And again, culturally congruent mentors and peers made it easier for them. In terms of compensation, this is not surprising in relation to Medicaid administrative burden, confusion navigating the Medicaid billing system, and low and unsustainable reimbursement rates were the top issues. This is something we know anecdotally, but we wanted to document. It's notable that 1/3 of respondents sometimes, very often, or always perform unpaid labor, and it'll be interesting to see how this might change when the new provider types are onboarded with Medicaid. Level of satisfaction with compensation. This was really split. And, with 44% somewhat satisfied, and then another about 40% were highly unsatisfied or somewhat unsatisfied. And one has to wonder if this doesn't break down along the lines of, setting where people are in more formal settings and get more higher compensation, more benefits, things like that, versus people in informal settings. And regarding compensation, mental health consultant in the center of the state says match the reimbursement rate for Medicaid with the commercial rate in the area. And the north, a doula and home visiting supervisor says increase pay so it doesn't feel like I'm the only making enough to survive. And this is also undervalued services are echoed by a doula in Madison and St. Clair. Likelihood to quit in the next 3 years, surprisingly, 50% said not likely at all. And that's pretty surprising for people. Half the people are making less than 60,000, or it might have been more than that, 3/4. So this is really work from the heart, I think, is what's driving a lot of people, not pay. Policy advocacy. We learned that about 3/4 of survey participants know people in their network who are working for change, but only 50% are part of a union or professional trade. So that tells us that a lot of this advocacy work is happening outside of formal channels, and most likely a bunch of it's unpaid and being done by workers themselves to improve their working conditions. Instead of giving policy recommendations to end, I thought I would just leave you with the policy recommendations that were left by people who took the survey, make abortions more accessible in Southern Illinois with improved prenatal care. There were a lot of calls for making VBAC clients allowed to use certified professional midwives, establishing a perinatal center of excellence for breech specialty, and ending collaborative agreement requirements for certified nurse midwives, full practice authority, and setting up mentorship programs for CNMs. And then more funding for home visiting programs to include doulas, clear policies for integrating doulas, and any and all new policies around immigration and deportation. Our families are living in fear and avoiding care. This doula in Madison and St. Clair had so many great suggestions: expanding mobile perinatal care units, telehealth options, home visiting programs, which I think everyone can relate to. And finally, people talked about just revising existing regulations and policies. This is so relatable, this home visitor from Champaign. We're state funded, so we have regulations and rules that to follow that don't align with lived practice of doing this work. Yes. And a home birth midwife in the east of the state, ability to open birth centers with fewer restrictions. We heard that a lot. So that's the end, and just want to say thank you to everyone for being here, for doing the work, and I'll hand it over to Anna.
Thank you so much, Nora, for that wonderful presentation. And all of the research slides, reports that are being produced and featured in this series will be available on our website, birthjusticeillinois.org. If they are not already up, they will be up by the end of the month, so you can refer to them at a later date there. And now, and if you have any questions, reminder to please put those in the Q&A function at the bottom of your screen, and I will pass things over to Chastity.
Thank you, Anna.
Can you see?
Yep. Thank you, Anna. I really appreciate it. I'm really excited to be here today, everybody. Thank you for coming. It's really important for Southern Illinois to let everybody know that we're here, we're doing this work, so we're excited to be able to present the study that we were able to do for strictly our area. So I want to start off by talking about a grant that we partnered on with Choices. Since Choices has came to Southern Illinois, they've been such a great partner to the Little Resource Center. And Choices received a birth equity grant in 2025 from IDPH. And the grant had two parts to it. So the first part was this study. We wanted to do a snapshot of the maternal health workforce in the southernmost 16 counties in Illinois. And we also were able to train a group of doulas. And that was really my portion. And I was so excited to be able to do that. So the second portion of the grant, we were able to train 9 full spectrum doulas in Southern Illinois. So just so you know, some background, when I first became a birth doula 7 years ago, I was the only Black birth worker in Southern Illinois. And when I say birth worker, I mean nurse, obstetrician, midwife, lactation, doula. That was never the end goal. So this being able to train these doulas was so important to me. It allows us to be able to expand the workforce to serve more families in our region. So we were able to graduate 9 full spectrum doulas. We brought down Sakana Collective as our certifying body, and the training was amazing with Sakana. We couldn't have asked for anything better. is also really important for me to bring them down in person, because I think that it's just impactful when you have that in-person training. The training was intense, the doulas will tell you, because I was in charge of it. And so it was very intense. They all were able to shadow with me. And I was very intentional about who I trained as doulas. It is really important to me that we have culturally competent care in Southern Illinois. So we were able to train 7 Black doulas. We have 2 bilingual Spanish speaking doulas, and then 2 of our doulas identified from the LGBTQIA community. Um, since the time of this study, we have continued that birth equity grant, and 5 of our doulas are actively working, taking clients. We're able to take so many more clients in Southern Illinois. And now 9 of the doulas that graduated are now in the process of training for certified lactation consultant. So this piece of the grant really opened up doors for us for as far as doula work in Southern Illinois. So the doula's intention to practice. So we did have one doula who was an intern from SIUC, and she did move back to Chicago, but she's practicing in Chicago. And then most of our doulas do still intend to remain in Southern Illinois. Like I said before, we have 5 doulas who trained with us who are actively working in our region, taking clients. 5 of them were able to get their Medicaid billing certification also. So the second piece was that environmental scan of the birth workforce, which was really important for us to do because we really just wanted to get kind of a background of where we are with birth, the workforce in Southern Illinois. So the objective was to scan our region to see where we are with work settings, where people are working at in the southernmost region. We wanted to see how are people feeling. As birth workers, I know the majority of us know, like, are we experiencing burnout? Are we satisfied where we are? We also wanted to see, like, are people staying? Are they going? Do we have people who are retiring soon? So that was part of our study. So just a snapshot of the Southern Illinois region. We're definitely very different than different areas of Illinois. So we are a maternity desert. We have 2 birthing hospitals in the southern 16 most counties. So we have Mount Vernon, Illinois, which is an hour north of Carbondale, and then we have Carbondale. So outside of that, those are our 2 birthing hospitals. So if you go west, you're going to go into Cape Girardeau, Missouri. If you go east, you're going to go into Indiana. If you go south, you're going to go to Paducah, Kentucky. So when you get down to the southernmost tip of Illinois, where you're in Cairo and Olin and Mounds, the people in that area, some of them do go to Cape mostly to deliver their babies, but most of them will end up in Carbondale. As doulas, we go wherever our clients need us. So we have been to Mount Vernon. We've also been to Cape. And if we have a client who is very high risk and they end up in St. Louis, we have been to St. Louis to support our clients also. Mostly Barnes Jewish, but there are other hospitals that they go to in St. Louis. We also have a high maternal obesity rate. We have significant perinatal mental health issues, substance use disorders, and we are designated as a high professional shortage area. So that's just a snapshot of what it looks like in our region. Much different than like Chicago, the city of Chicago, I know, but that is what we deal with in our area. So I also want to give you an idea of what it looks like for us for providers. So we have 3 dedicated OBGYN practices. So one of those is Shawnee Healthcare. Shawnee Healthcare does take Medicaid clients, and they deliver at Carbondale Memorial. Then we have Heartland Regional, which provides prenatal care for our clients. Heartland now only delivers in Mount Vernon, and that was something that recently happened within the last 2 to 3 years, and that has been a strain for our clients because we only have two providers that take Medicaid, which is Shawnee and Heartland. So if our clients have Heartland, then they're going to deliver in Mount Vernon. And we have huge transportation issues in Southern Illinois. So that's definitely an issue, a huge issue in our region. Then we have one other provider, and that is SIOBGYN. SIOBGYN delivers at Carbondale Memorial, and they only take private insurance. And then we do have two FQHC providers in Southern Illinois. We have 38 OBGYN providers, including mid-level, that currently serve in the 16 county region. So we had a 41 question instrument. We hosted it through SurveyMonkey. We opened it up May 1 through June 7. We did provide a gift card for incentive, confidentiality for all of the questions. And we took like a profile. We wanted to know their experience level, where they're working at, which environment are they working at. We distributed via email. We did targeted online recruitment, direct mailing. One-on-one outreach was very huge. Just reaching out, to other doulas, RNs in the region when we were in the hospital, just the relationships that we had reaching out to different providers. We did clinical and non-clinical maternal and child health professionals across our region. So we had 99 respondents. Most of them were RNs, doulas, of course, medical assistants. We did have a broad representation of experience levels. Average experience was 9 years. We had 3 OBGYNs respond, 1 family medicine provider, 3 pediatricians, 1 maternal medicine specialist, 1 emergency medicine. Most of the respondents did come from Carbondale. We had a few respondents from Marion, Murfreesboro, Pinckneyville, and Heron. So if you take a look at the work settings, most of the respondents worked on L&D units. Some respondents in community-based organizations, that's mostly going to be our doulas. Some respondents did work at public health departments, some at reproductive health clinics. Many respondents reported working in multiple environments. If you're a doula on this call, you know that as a doula, you are stacking your work. So doulas are certified doulas. We are lactation consultants. We're doing massage therapy sometimes. Some doulas are also photographers. There's a reason for that because usually doulas are not making enough money to be able to sustain themselves. So that means that you're working long hours. I referred to what Nora said earlier. Most of the time, this is hard work that we're doing. And that's really important for everyone to realize that we are trying to make sure that our birth workers are making a living wage because we need the support for the families in Illinois. Average work hours were reported was 38 hours a week, and then travel was about 16 miles. So this section responded to the adequacy of like workplace equipment, support systems. So as you can see, we are reporting increased funding. Of course, I just talked about that. We need to make sure that our respondents are making a living wage. Enhanced collaboration with other healthcare professionals. So I know that if you work in birth work, you know that sometimes it can be disconnected and disjointed. We just want to make sure that everybody understands working together is what's going to provide better for families, better patient Outreach programs are really needed in our region, especially with transportation issues and the different issues that face our community. Enhanced, I would say, provider collaboration also, especially when it comes to doulas. I can speak to. We just want to make sure that everybody knows that we're just that extra layer of care. So providers knowing that doulas are out here and providers referring to us is really going to help the families in the long run. So workplace well-being is really important. We as birth workers, we all have to make sure we're taking care of ourselves, because if we're not taking care of ourselves, we're not going to be able to continue to do the work. So we did see that some workers are feeling burnt out. Most respondents feel that they're managing job demands really well. There was some burnout that we found. So that's just something to take care of in the future. So retention, we did find that some of our providers will be retiring soon. So that's something to look out for in the future. If we have providers retiring, will we be able to bring other providers into the Southern Illinois region? We did have some respondents who said that they would be staying with their current position over the next year. Um, there is a decline in the current roles in the geographic region over the next 5 years. So RNs, obstetricians, midwives looking to retire, how are we going to be able to bring in new roles? So everyone in our region has this concern. OB coverage and hospital changes. Remember, I talked to you about this before. We only have 2 birthing hospitals. The travel for our patients, most of our clients are traveling an hour away. When we already have transportation issues, that is huge for our region. We all worry about this. Even as a doula, I worry about my clients having to travel an hour for prenatal care and an hour either way to be able to deliver. We're definitely working on that long term to see how we can work with this. Increase in burnout, particularly from staffing shortages and heavy reliance on senior staff, is an issue. Non-clinical roles, so doulas, community health workers, WIC staff are identified as critical for continuing care amidst the instability in our region. We, of course, have a need for more doulas, but also bilingual services, and not only Spanish. Yes, there's a high need for Spanish, but we have a high need for other languages in our region that we're seeing more and more. And also inclusive care. So making sure that we are providing care for everyone. So LGBTQIA plus community and people of color. So conclusion is committed workforce. So maternal health professionals in Southern Illinois demonstrate high resilience and dedication despite the significant challenges that we face. We want to make sure that we're addressing burnout. We want to have retention. Keeping our birth workers in the region is going to benefit our community in the long run. And we want to make sure that we provide any gaps in coverage, continuing to provide the critical care that families need. So recommendations are enhance the workforce retention, improve integration and sustainability of community-based roles like community health workers, doulas, and home visitors. Little Resource Center is continually doing that. We just put a community health worker into our library to provide for the community. We are continuing to get more staff like doulas and community health workers at the Little Resource Center to make sure that we are continuing this. We also continue to partner with Choices. I want to add that Choices is now providing family planning. Um, Carrie Stewart presented last week, and she is now the director of family planning for Choices in Carbondale. I'm so excited about this. I could literally scream because this is huge for Southern Illinois. Just continuing to partner with Choices allows us to continue to bring quality care to our region. So this study was actually conducted by Claire Hughes, who is my business partner at the Little Resource Center Carbondale, Lundy Lagoria, who works for Choices, and Tracy Smith, who I'm sure all of you are familiar with. The doula training team was myself and Candace Akintola, who's also a doula with Choices and the Little Resource Center, and the project manager was Wendy Anderson. The contact information on the screen, that is Claire's email. You can reach out to me though, and of course I can reach Claire. And then Jamie Buller is also with Choices, and this is Jamie's email address. And thank you so much, everybody. I really appreciate being here, being able to prevent for Southern Illinois.
All right, thank you so much, Chastity. We are now going to move into the Q&A section, and there's not a lot going on in our Q&A box, so please feel free to add any questions that you may have for either or both of our researchers. In the meantime, there is one question here. What other languages are you seeing? I believe that question's for Chastity.
So let's see. I myself am not seeing a lot, but that's because I'm not at labor and delivery all the time. But the nurses have mentioned to me that they're seeing a lot of different languages come through, and they would just rather not be using the iPad to be able to, translate.
Kate asks, is there a sense of how many CPMs are practicing in Southern Illinois? Either of you feel free to take that question.
So there's a pretty significant amount. I would say there's about 10, and that's from Mount Vernon all the way down to Cairo.
And are those all home birth practices, Chastity?
Yes.
And I think that, looking at the data that you presented, Chastity, there's only, 3 OB practices?
There's 3 practices, yes. So Shawnee Healthcare, Heartland, and SI OBGYN are the practices.
Yeah. So having those, go ahead.
Oh, no, I was going to say CPMs. Melissa Coelho is one that people may be familiar with. She's a certified nurse midwife. She used to be part of a practice that no longer exists in our region, but she is a home birth midwife now. And there's several others. I did not know that the group was so large until I started in birth work, but we have a meeting every 3 months. I can't name all of them for you, but they are definitely in our region practicing and serving clients.
There's a couple of questions here about, are there any upcoming birth justice doula trainings? I assume I assume these questions are for Southern Illinois specific, but maybe they are more broader statewide.
So we may have a doula training coming soon. So honestly, the Little Resource Center is most active on our Facebook page. So if you take a look at our Facebook page, when we have a doula training coming up, I will keep you posted. Also, I'll put my email in the chat, and just email me, reach out to me, and then I'll put you in my contact list, and I'll let you know once we have a training coming up soon.
Nora, is there anything you want to add to that?
I was just putting some names in the chat. I know Bania, they have trainings in the Chicago area as well as Socana Collective. And yeah, I think people are putting some other ones in there. Hmm.
And I will say that one of the goals of one of the goals of the strategic plan is to really provide a centralized place where folks can say, hey, I want to become a doula, I want to become a certified lactation counselor. Who's doing these trainings? When do they start? How much do they cost? How do I get connected? So we'll be working to make sure that those opportunities are much more easily navigatable and accessible. There's a question about transportation barriers. With all the transportation barriers that are being described, how are people traveling to specialized centers and getting the care that they need?
So mostly in Southern Illinois, they're using their Medicaid insurance. So as long as they call 3 days before their appointment, they can even get rides all the way to St. Louis. We do have issues with that, as I'm sure everybody in Illinois does. Sometimes you set that appointment and they just don't show up. So it'll be like Uber. Some social service organizations will provide gas cards for them to receive rides. Local to the Carbondale region, we do have a bus system that they can take. There's also like a door-to-door service. It's called Jackson County Mass Transit that they can take. So there are ways, but there are just so many barriers in the way sometimes.
Yeah. Um,
I was
Someone
gonna
put,
say on the transportation issue, there's if people know femur, it's the fetal infant. I'll put a link in the chat, but there's a one in Chicago, one in Southern Illinois, and they have, oh, Jose is in the room, Jose Ortiz. So if you might want to drop your links in there, they have toolkits um, for accessing those transportation systems. There you go. Yeah, and they're amazing. They have little cards, information cards you can give to clients. There are issues with the transportation, like Chastity said, and some people said in the link, but just for birth workers to have those resources readily available, they could check out the toolkits. And he's put the link in the chat. Thanks, Jose.
thank you. And just a reminder to please put your questions in the Q&A box so that we can make sure that we get them. Question from Lon about how receptive are OBs to non-hospital birth settings. I think this relates to some of the integration challenges that have been mentioned by both of you. And while you're answering that, if you have any recommendations for how to facilitate positive receptions, please feel free to comment on that as well.
So I know that there's one provider here. His name is Dr. Bishop, and he has a relationship with the home birth midwives in our region. So I mean, there's just a smooth transfer there because we have Dr. Bishop as their contact. Now, there's a worry when Dr. Bishop leaves, who will be that smooth transition? Because right now he is the only connection that they have.
Yeah, I mean, I would just echo that, from the research we've done and just from lived experience, it's really spotty, the reception. So we do have some champions in some institutions, and we really gravitate towards them because they understand and respect our professions. But there is a lot of resistance. There's a lot of resistance of people who, honestly are in policy making positions and not just in hospital administrative and hospital, um, you know, clinical positions. So it's a big hill to climb. I mean, I know my sister's an L&D nurse in Chicago, and whenever a doula shows up, she is just so grateful. She is so happy that this person is going to get what they need because she just doesn't have the capacity to be with one person throughout, especially if they're younger or non-English speaking or not familiar with the hospital environment. It becomes or a sexual abuse survivor. There's a lot that goes on, and doulas are the experts in that. They mitigate all of those potential risks to make better outcomes. And I think that, there is a real opportunity, especially now that a lot of the providers are recognized as Medicaid um, uh, providers that number one, I think there's an incentive now for institutions to bill for that kind of thing. So we actually have insurance MCOs recruiting doulas actively because they need to have them on their rosters. And I think the same will be true for CPMs, lactation counselors, but uh, it's still a lot of resistance, and we're going to have to do a lot. We do a lot of educating, we do a lot of relationship building. There's a lot of trust that needs to go into these types of relationships, especially as a CPM transferring from out of hospital to in hospital, because there's a huge question about whose liability is it. There's a lot of superiority in the medical professions, and our work is not always valued. And I would just say that, there's a place called the Birth Lab in there's a university in Canada, the Birth Lab, and they do a lot of work around collaborative models of care and interprofessional collaboration. And I think Illinois needs to move in that area. And what that looks like is doing trainings together, having agreed upon protocols for transfers, doing like case reviews when something doesn't go great, instead of, blaming and shaming and shutting out that practitioner, even if it's, someone in the community or someone in the hospital, to actually lean in and go toward and do a collective case review and figure out where we can improve, as opposed to more of like a punishing system. So those are just some ideas around that.
And I would also add that as far as doulas are concerned, I'm finding the more work I do, the more doulas are being accepted, the more referrals we're getting. But I do always point that out. So Melissa Coelho is a home birth midwife, and she requires all of her first time moms to have a doula because she knows that she doesn't have the capacity to spend as much time with her clients as a doula can. Um, so I always say, like, why not? Why shouldn't all first time moms be required to have a doula? Now, is the workforce out there for everybody to be able to have a doula? Maybe not, but we could start trying it,
Not yet.
like, not yet, right? So we're working on it, but I just know that the level of care that I provide to my clients, like being able to go to prenatal appointments with them. Um, right now, I have a homeless teen client, and I have been to every one of her appointments with her. I'm providing that extra layer of care. We may have her housing by the end of this month. And without that doula being present, these things may not have happened for her. So I just know that just continuing to understand that a doula is an extra layer of support for families that's so needed. Um, and so providers to understand that is really, really key.
Thank you both. So there is a question here about if mainstream provider education is a component in the strategic plan. The answer is yes, enthusiastically yes. Exactly what Nora and Chastity were talking about is that there needs to be education. There's a lot of misunderstanding and misinformation out there about the role of community-based birth workers, and that they are complements and not usurpers of the care for birthing people. So that is absolutely a component of the strategic plan to provide some co-education, relationship building, and trust building, and protocol building across clinical and community staff to make sure that there are those smooth transitions in place. It's a question here from Alexis about how do we increase diversity in the birth work field?
I mean, so I was just intentional about the doula training that I did. I recruited and I interviewed, and If you're in Southern Illinois, people will tell you like Chastity's always talking about these doulas. Yes, because it's so important. So I let people know like if you're interested in being a doula, reach out to me. I tell people that it's really important to have culturally competent care. So I just continue to tell people. I also think it's important to open up that path. Some people may not know what a doula does or how they can become a doula. So just a continuous education. Also, I've spoken to high school classes, I've spoken to medical students. So all of these are ways to introduce doulas in that career path to a diverse audience.
Yeah, and on that one, I would just say, the kinds of things that Chastity is doing, we really would love to see as a coordinated, collaborative, statewide, um, and funded effort. And I know, at Black Midwifery Collective, we are working on the direct entry midwifery program at Kennedy King College in a largely Black neighborhood where a majority of the students at the school are Black or Latina, and where the maternal mortality rate is really high in the state. So putting these kinds of programs in the areas of highest need with the intention of growing birth workers in their regions, in their neighborhoods. So you don't have to travel to another state or another part of the state to get your training and to continue your continuing education and certification and to grow, to get more certificates and experience. And a lot of this really is funding and intentionality. The other part I would say is also leadership, right? So there's Chastity doing a cajillion jobs because she was the one first Black doula. The work of choices down in the southern region is so important with Nikia and Grayson and Carrie Stewart. They are training Blacks or CNMs of color and just CNMs in general down there. So intentionality, leadership, supporting our leadership and funding. So, for the Kennedy King program, we were really looking at trying to cover most of the costs for students because it's when you're training in these kinds of things, especially when you're on call, you can't have another job. You can't have a job and be on call when you're a student in a, clinical phase of your training. So.
Yeah. And we do also in the strategic plan have a goal around coordinated recruitment, outreach, awareness, education around these roles. So, another exciting thing that is coming out of this data that we have a direct response to in the strategic plan. There's a question around advocacy. What does advocacy look like in Illinois with elected officials? Florida just had our Birth Justice Day at the Capitol.
So that's great. I mean, I know what for CPMs, there's a few organizations, Black Midwifery Collective and the state CPM group that do advocacy. Would love to hear, and again, a lot of it's unpaid. We raise funds from private foundations to cover our time to we've worked on Medicaid reimbursement rates, we've worked on passing the CPM law itself, we've worked on Medicaid, I said that, rules and regulations. I'd love to hear what it's like for, like on the home visitor, the doula, the SUD front, because it's really patchwork for us and it's unfunded. Like I said, a lot of people are doing advocacy work and not a lot have professional organizations that represent them. Yeah, health and medicine policy research, they're a great one. I know Illinois Public Health Association, Tracy Smith, IPHI in Chicago. There are some kind of nodal organizations that do it. But a lot of it is more education, raising awareness, um, talking to elected officials and then witness slips and things like that. Some of it is law passing, some of it we do have a pretty good policy environment in Illinois compared to other states. There's always more to be done, but in terms of mobilizing people like to go to the Capitol and things like we haven't done a lot of that. And um perhaps that's something that will come out of the plan if there's something that enough people rally around. Mhm.
So as far as doulas, so we definitely met with the state around Medicaid reimbursement for years before that passed. Um, I know that started with a meeting with Juliana Stratton, Lieutenant Governor Juliana Stratton, and a group of doulas in Chicago. And she asked them what they needed, what they wanted to see. And I know that they had that conversation, and that led to meetings with the state, and that led to Medicaid coverage. Um, it actually looks like Nora said, doing a cajillion jobs and going to meetings and constantly talking about the work and making sure that people understand that doulas are here and we're doing the work and that we need funded. And, so it's just, like Nora said, I think it's patchwork work, but across the entire state, I know that doulas are on the ground doing the work.
And we've got a couple shout outs to EverThrive in the chat here, also doing critical policy work in this area. Thank you to our partners at EverThrive. And yeah, it is patchwork though. And it's another thing that's in our strategic plan is the need to have a cohesive, a unified center for advocacy around these topics to make sure that we are rallying all of the people power we can to help push the legislation that birthing people need and deserve in Illinois. A quick question for Chastity. What hospital is Dr. Bishop affiliated with?
Heartland now. I'm sorry, Good Samaritan in Mount Vernon. So Heartland used to deliver at Carbondale Memorial, but they no longer deliver there. So Dr. Bishop is connected to Good Samaritan. But I will add that Melissa Coelho is a certified nurse midwife who used to work at Carbondale Memorial. So when she transfers clients, all the staff there know her. So of course it's going to be a smooth transition for her also.
Thank you. And okay, I don't see any more questions in the chat. So my final question to both of you is if you had one key takeaway that you want someone to remember as a result of your presentation today, what would that be?
Did you say 2 takeaways?
You can give 2. I asked for 1, but I'll give you 2.
I would just say jump in, join in. Collaboration is key. Trust each other, build relationships, and funding. We need, we're grateful to the people who have funded this work. We're grateful for that trust and support and to continue that. But as a collaborative, so we're all have a voice and we're all sharing. And just wanted to give out a shout out to a chat in the comment in the chat with Bonilla. They're facilitating the doula coalition across the state now that's forming. So you can get in touch with Bonilla about that. And it's an exciting time in Illinois. Get involved and help push this work forward.
My key takeaway would be I'm in Southern Illinois, and it was really important for us to be included. All across the state, we're doing this work. We're here. We are a special region, right? We're a maternity health desert, but we are here serving our region, and we want quality care for our region. So just know we're down here doing the work. And I would say funding, jump in, reach out to us. And this strategic plan that these meetings are so important. this community-based plan that Star August Ali and Black Midwifery Collective started is so important. I just can't stress that enough. So thank you very much.
Thank you, Chastity. Thank you, Nora, again for your time, for your work, for your expertise in this space. We are so grateful for your leadership. And we're not done yet. We've got a couple more sessions to go before we launch our strategic plan in full. So the next 2 Fridays, we'll have sessions 3 and 4. Next week will be themed racism, discrimination, and their impact on Black birthing people. So we will delve a lot more into that topic. And our final session on February 27th, we will bring back all of our PIs that have presented in the first 3 sessions and talk about some of the overarching themes that came out of their data and how they inform the strategic plan. And then we will, of course, go through the strategic plan in full. You'll be able to see all of the really clear connections between what the data is telling us and where we are acting to help address some of the needs in our community. And we, of course, invite anybody and everybody to join for those conversations. You can register at the QR code right there. And big thank you to our researchers, again, to Chastity and Nora, to the coordinating committee members who helped guide this work, and the strategic plan advisors who contributed to the strategic plan. All of the people who participated in these studies and the funders who support this work. You can see a full list of all these folks on our website. I also want to give a special thank you to the Black Midwifery Collective and to Star August Ali for their incredible leadership in this space, because these conversations wouldn't be happening without you. And it's been an honor and a joy to be working alongside you on this work. And finally, you can check out our brand new website. It is beautiful. There is not all of the pages are active yet. We will activate them at the end of the month after our final session, but you can check out a lot of content there already. Especially there is a tab for reproductive justice, birth justice history. That's an interactive timeline. It's really beautiful. I encourage you all to take a look to see where we've started and how far we've come. And then the QR code on the right is an interest form to get connected, whether you want to participate in the strategic plan, you just want to get a quarterly newsletter about what we're working on, or something else, aligning your work with ours, you're working on something that's similar. We don't want to duplicate, we want to elevate. So please let us know how we can connect, how we can collaborate. And I think that is it from us today. Thank you, everybody, so much for your participation this morning, for your passion, for your hard work in this space, and have a lovely day, as our friend Bill started us off this morning. And hopefully we will see you all next week for session 3. Have a good weekend, everybody.